Welcome to the June 2025 Talk with the Doc with Dr. Timothy Licklider. Thank you everyone for joining live, or perhaps you're watching this later. Thank you, Dr. Licklider, and please take it away.
Thank you, Casey. Welcome back to the party, everybody. I agree. I think June is normally the start of summer, although the weather looks better earlier than it does right now out my window here. But welcome back, everybody. I am Dr. Licklider, so-called movement disorder specialist here at Allegheny General, which is where I'm sitting in my office. Welcome to Talk with the Doc. So short part of this is you ask questions, I answer them to the best of my abilities. Caveats I always throw out there is this is not a great place to get your own individualized, personalized care. Don't ask me questions about, well, I'm on this and this, and what should I do next? That sounds like a great question for your doctor. Even if it's me, this isn't a great place to do that. And the other thing I like to say is everything you get is my opinion. I have a lot of opinions. I generally share my opinions, especially if you ask. But nonetheless, they are my opinions. If you go to a different neurologist or you have a different movement disorder specialist or you read something different, you might have a different opinion, and that's okay. You're going to get mine because that's what I got. I like to think my opinions are usually based in science as best I can, but sometimes I do have to make stuff up, and I'll tell you I'm making stuff up. So let's get started. I did get some questions emailed to me, and I thought they were pretty good questions. The first email that I got was actually a couple of studies or kind of news clips. And it was basically what are my opinions on those. And so I have no problem sharing my opinions on them. So the first one was about actual use of microdosing of psilocybin. So that's basically the drug in mushrooms, the psychedelic drug in mushrooms. And this has actually been looked at in medical conditions, neurological conditions using tiny, tiny dosages. And this was showing that I think over in California, University of California, San Francisco did a small study where they took a dozen people with Parkinson's disease who also had anxiety, and I'll come back to why I think that's important in a minute. Um, and they gave them really low doses of psilocybin, and it actually did help. Not only was their mood better, but theoretically they moved better as well. Now, the caveat to this, and even in this news clip, the caveat that they said was the goal of this was to show that maybe it does have some benefit to it and to help push research along. Um, and in quotation marks, it says, I wouldn't recommend to my patients with Parkinson's that they start using psilocybin. She clarified, we were very eager, very early in this research, and we don't think these drugs will be safe for everyone with the illness. And so the short answer to what I think is, sounds great. Let's look at it. Let's research it. Let's do the appropriate studies. Let's figure out where it works. And so I'm not recommending magic mushrooms to my patients just yet, at least not for this. And the reason why I pointed out that it was given to people with Parkinson's disease with concomitant anxiety and depression is the same ideas that I see in medical marijuana use, which I am a certifier of. I have not had a lot of true benefit in my patients for the past, I don't know, 7 or 8 years. I don't know how long it's been approved. I've been a certifier basically since I think it was Tom Wolfe approved it or suggested it. And so I've been using it in some of my Parkinson's disease patients, but I have not had a lot of true success with the typical Parkinson symptoms, tremor, stiffness, movement problems. But where I have had some success have been things like anxiety, probably one of the bigger ones, pain, sleep problems. Now, a lot of my patients with Parkinson's disease don't sleep very well, have a lot of pain, have a lot of anxiety for whatever reason. And so, secondarily, using things like medical marijuana, and I wonder if this would be the same thing. Everybody on this call has probably recognized that if they're anxious or they're in pain or they don't sleep very well, that their symptoms get worse. They shake more, they're stiffer, they don't move as well. And so secondarily, if I've been able to help one of those other symptoms that has, at least in some patients, help them move a little bit better, feel a little bit better, shake a little less. And so I wonder if this is going to be something similar to that. Again, we don't have good research trials on medical marijuana either, and so I very rarely actually am the one to recommend it. Because again, my stance on recommendations usually are there has to be pretty good evidence for me to recommend something. But if we talk about it and patients are interested in things like this and it makes sense, I'm not against trying it in those certain circumstances. The other study or the other kind of Sci Tech Daily, whatever that is, news article or publication I thought was really interesting. So it was brain reset. One molecular switch could silence Alzheimer's and Parkinson's. And I read through this and I thought it was interesting. So this guy, Joseph something or other, I forget his name, basically came up with this theory that there's one unifying underlying biochemical process that is not working correctly in both Alzheimer's disease and Parkinson's disease. And he was basically tracing back the pathways to both underlying disorders to this one step or this one biochemical process, which was basically deamidation, translational control oxidative stress and neurodegeneration through axon-based blah, 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 blah. Bunch of big words that I don't even understand myself. And I thought it was interesting because we don't typically think about Alzheimer's disease and Parkinson's disease as the same underlying biochemical process. Generally, in the idealized world or the textbook world, we think about Parkinson's disease as an alpha-synuclein problem, alpha-synuclein being this protein that misfolds and clumps in together to cause Lewy bodies, which is what we see when we slice open the brain of somebody with Parkinson's disease. And in Alzheimer's disease, we typically think about tau, which is a completely different protein that clumps together in neurofibrillary tangles and amyloid beta plaques. But what he was suggesting that actually even before those misfolded proteins, there's actually an inflammatory condition, which is what triggers all of those things. And his thought or his theory is that if you go back beyond that and you start targeting this type of area, that maybe you can actually correct, treat, or even potentially fix both. And I think that's an interesting idea. Again, I'm always interested in anything that might help me treat patients better. I do not have a disease-modifying medication. I do not have a fix. I do not have a cure. I am open to suggestion for all of those things. But what, again, the kind of the frustrating part is you read through this paper and you realize it's just a theory. This hasn't even been studied, I guess is the best way to put it. They have not come up with a medication or any actual thing that targets this area. And so basically, this is very, very, very early in terms of could this produce something that gives us some benefit. So while I'm interested in stuff like that, I will always read stuff like this. I will always give you my opinion on stuff like this, but I don't get very excited about stuff like this because ideas like this, while important, are still very, very, very far, in my opinion, away from actually giving me something that I can get in my hands and I can give to you to take and actually do better. And so while all the things that I look for have to start with an idea, which again, this is an idea, I will be much more excited about this once I see it in process, in progress, in actual trials, targeting this area and seeing the benefits that we need to see. Then you'll hear more me talk about it more. I'll get as excited as I get, which is not very excited. Trust me, I almost never get very excited. But again, hey, there's always hope. The other questions I thought, were interesting. So the next questions I got were about memory. So how does daily short-term memory affect your ability to drive a vehicle? And that's an interesting idea because again, potentially, memory problems can lead to driving problems, right? You have to know which one the gas and the brake are. You have to know how to navigate turns. You have to use turn signals. Driving is a complex activity. You have to remember where you're going, or how you got there, or where you came from. And so all of these play a role in driving. But at the same time, I have seen plenty of patients who maybe do have some mild cognitive impairment or some underlying memory problems who drive just fine, who don't get lost when they go places, who, again, maybe they keep things local and they know how to navigate their area. And as long as they don't go on highways or too far out of their way, they do just fine. And so that's a really hard question for me to answer. I actually don't think I'm properly equipped or the right person to answer that question because I'm honestly not sure at what is the tipping point. How much is too much of a problem that actually impacts driving? And I also don't like to be the bad guy, believe it or not. I'm the bad guy 9 times out of 10 in the office. I mean, I am not usually the bearer of good news. And so I don't like to be the bad guy more than I have to be. And probably the biggest bad guy that we are in neurology is when you tell people they can't drive. Probably the epileptologists do this the most because if you have a seizure, your license gets restricted. Um, but that's really because of how much driving or prohibiting driving or restricting driving really takes away freedom. Um, I lived in Philadelphia for a little while when I was in medical school, and let me just tell you, the public transportation outside of Pittsburgh is significantly better than it is in Pittsburgh. In Philadelphia, there was a subway system, there was a train system, there was a bus system. And the one thing I'm not a huge fan about I love Pittsburgh. I'm from here, and this is where I plan on staying forever. But the one thing I'm not a huge fan of is our public transportation system. And everything the patients tell me about the use of access or the transportation that is theoretically available is not very good. And so when you restrict somebody's driving, you really limit that person's freedom and that person's ability to do the things that they want to do. And so none of us in neurology are really all that excited or eager to start taking people's licenses away. And so that's a long-winded answer to try to tell you that I'm probably not the best person to try to answer that question, although it is an important question that should be answered. Just as an aside, driving questions come up all the time in my office, not just from a memory standpoint, but also from a physical standpoint. Again, with stiffness and slowness of movement, reaction time is impacted. Ability to drive can be impacted. I also don't think I have the best ability when I'm doing my examination in the office to really tease that out and be a good judge of how well you can or can't drive. And so the way that I do it, which is sort of a way that I take myself off the hook, but also I think really the best way to do it is I oftentimes will defer or refer to whoever comes with you. My argument is that significant others, close family and friends, are probably the best indicators of whether or not you should be driving. And I know this through experience. And so since I don't like to be the bad guy, and usually the way it goes is that, the patient's wife or husband comes in and slips me a note and says, "Hey, I want you to talk about driving because I don't think they should drive, but I don't want you to tell them that I said that," which never works, by the way. Is we do end up talking about it in the office. And the way that I end up deciding, making that decision is I go generally with whatever the significant other or the other person says. Now, it's obviously easy when both parties agree. The patient agrees, the family agrees, they both agree you can drive, you can drive. They both agree you shouldn't be driving, you don't drive. Obviously, the problem comes up when, Mr. Smith's wife comes in and says, "This guy should not be driving." And of course, Mr. Smith says, "I'm the best driver that's ever been created. I've never had an accident. I have absolutely no problems driving. What's wrong with you?" And so then I am put in the position of trying to decide. And of course, I answer it without actually answering it. I say, "Go take an on the road driving test. Prove to me that you are a perfectly capable best driver in the world." And I will absolutely say, "Nope, you stop talking. He is a good driver. He can drive." I'm getting a little bit off topic, but just as an aside on that front, I can tell you that of the people that I have personally sent for an on the road test because their significant other came in and said, "I don't think they should be driving, but they thought they should be driving," my success or pass rate is 0. 0. Now, again, I've probably only sent maybe a dozen, 2 dozen people for an on the road test. This is not a common thing, but not a single one has passed. And I use that to describe to patients that realistically family members, significant others, close friends, close neighbors, close family are really good indicators as to whether or not you should be driving. In my experience, they have a 100% success rate in determining who is going to and who is not going to pass that test. Again, doesn't mean you can't go take it. I am more than welcome to allow my patients the opportunity to prove that they can indeed drive. And yes, it does require an on-the-road test, but that's the best way to do it in my experience. That way I don't have to be the one to make that decision and be the bad guy. That's just the way I do it. Other providers, other neurologists, other movement disorder specialists may have different opinions, but that's just the way that I usually do it in my office. That was a very long-winded answer for a very short question, but I like to clarify that because there's a lot of questions that come up about driving ability, and it's a really difficult but important thing. The follow-up question to the original question is, are there medications for short-term memory issues? And of course, the answer is yes and no. I have a medicine for just about everything. Are they very good? Probably not. And so generally the medicines that we have when we start thinking about memory, short-term or long-term, although I would argue that short-term is even more difficult, are the Alzheimer's disease medicines. So the medicines that we'll use are Aricept, Namenda, Exelon. These were medicines approved for the use in Alzheimer's disease. And that's because there really aren't any medicines that were invented for the use of Parkinson's disease dementia or memory problems. And so we steal medicines from wherever I can, and the memory medicines usually fall into the Alzheimer's disease category. The hard part in thinking about these medications are that the medicines, even in studies and even what their approval is for, is not to make you remember better. That's what everybody hopes. That's what I hope. That's what you hope when you take them. But realistically, that's not what they're shown to do. They're shown to slow down decline. Now, that's great. Everybody wants to slow down decline. But I can tell you 10 times out of 10, patients come back and say, I don't think it's working. I'm not remembering any better. If anything, I'm getting worse. Now, the hard part to that is with these medicines, it's really difficult, if not impossible, to actually know if they're helping. They got approved because you can do a randomized controlled trial. You can give 500 people the medicine and 500 people get a placebo. And you can say, look, the people who took the medicine tended to go downhill at a much slower rate than the people who didn't take the medicine, right? I mean, that's a randomized controlled trial. That's how drugs get approved. But in any one person, there's no comparator. There's no good way to know if that medicine is helping. And so the short answer to the question is yes, I have medicines, but no, they don't do what we want them to do or what we wish they did. I still use them because they're really the best that I have, but they're just not as good as any of us would really like them to be. Now, I always recommend exercise because I really do think exercise helps from a memory standpoint. I actually learned giving this talk, and I can't remember who it was, but I still quote you or thank you that there is, because brain games are the next thing that get asked about. And there's very limited data, with the exception of Brain HQ, which is a speed of processing brain game. Now, the downside to Brain HQ is it's not free, and you do have to pay for it. But I was impressed by the evidence that I looked up because somebody brought it up on here in terms of actually helping improve memory or slowing down cognitive decline. And so, again, there are some things we can do. They're just not nearly as good as we would like them to be. Then the last question I got on this email was regular exercise is important for Parkinson's disease. I 100% agree with that. But how does speech exercise fit in? Should it be done daily, weekly? What are the best exercises from a speech standpoint? Donna, give me 1 second, and then I'll come back to you. And I don't know the answer to this question, actually. Believe it or not, there are a lot of things written about how much exercise you should do. The government, the CDC, um, you know, the NIH, they all have recommendations about physical exercise, and it's 150 minutes a week if you're interested. Just about everybody has come to that same conclusion. But I've actually never read any actual recommendations, indications that this is the kind of speech exercises you should do. This is how often you should do it to maintain. I would probably defer that question to a speech therapist. But at the end of the day, it's really whatever helps you maintain whatever you're trying to do. So a lot of speech exercises maintain volume, they maintain speech clarity. And so if you can get away with doing them once a week and that helps, then it's once a week. If you need to do them every day, that's fine. But one thing I am fairly sure is if you don't do it, you lose it. Now, I don't know how long you have to go without using it before you lose it. And that comes back to sort of the answer to that question. But I would defer that answer to a speech therapist. And in fact, next time I see my speech therapist, I will try to find out an answer to that question on what they recommend, because I honestly don't remember ever seeing those recommendations or seeing hard, fast rules about kind of what we should or shouldn't be doing. All right, Don, I'm going to give you a quick, a brief time to say whatever you were going to say, even though I know it goes against what Casey just said.
I just want to say that I think I told you about Brain HQ, and it,
Yeah,
it is free if you just use it once a day, and it tracks your progress. So if you want to try it out, it's free. And you could use it every day. One time they give you a test a day to help improve different areas. So it is free for that.
great. And thank you. I've been telling people about it whenever they ask, because everybody asks about brain games, and that's the only one that I know actually has some good evidence. So I thank you for that. I thought this was a really interesting question because I've honestly never thought about this. I actually did look this up a little bit, and I thought the answers were a little bit interesting. So the question was, if other neurological issues that are affected by dopamine levels are not addressed, such as autism, ADHD, and bipolar, Could that contribute to Parkinson's or make it worse? And could specific drugs used in treating these conditions help with Parkinson's? And so I thought that was interesting because I believe me, I'm not an expert in autism, ADHD, or bipolar. I don't treat any of those things directly. I believe definitely ADHD and bipolar are most often taken care of or managed by a psychiatrist or a primary care doctor. I would imagine autism would be as well. So I did go back and look, and there is some evidence that dopamine plays a role in each of these things. The hard part is we're not entirely sure how. So a lot of it seems to be dopamine processing or how your brain handles dopamine that leads to some of these conditions. Interestingly enough, autism was simultaneously research shows maybe too much or not enough dopamine, much like some of the research in Parkinson's disease. But the treatments that I saw for autism were really aimed at outbursts, anger, and behavioral disorders, which of course led to the antipsychotics, which can lead to Parkinson's symptoms. And the same thing is true for bipolar. Even though the mania in bipolar seems to be too much dopamine and the depression in bipolar seems to be maybe not enough, but it's probably more about how dopamine is processed and handled. The only treatments I've never seen dopamine used as a treatment for bipolar. Same thing is true for ADHD, which I was looking up, which does have some evidence that maybe it is a low level of dopamine, but I've also never seen carbidopa, levodopa, or the dopamine medicines used as treatments for ADHD. It's always the stimulants which affect more norepinephrine than dopamine, which are all very similar in mechanism or very similar in composition, but different in terms of what they do. And so, but then retrospectively, I also thought about how the patients that I've seen over the past 10 years, and I can tell you, I don't, maybe I have seen probably ADHD. I've definitely seen some patients with Parkinson's disease and ADHD, but I can't think of a single, maybe I've seen a couple, but I'm not sure offhand, autistic patient with Parkinson's disease or bipolar patient that I thought was true Parkinson's disease and not medication induced. And so even though we know that dopamine, or apparently we know that dopamine plays a role in these conditions, that is not what I'm typically used to seeing in my office. And if they really were directly or similarly tied to dopamine the way the Parkinson's disease theoretically is, I wonder why I haven't seen it as much in my Parkinson's disease patients. Now, again, my patient population is obviously a very biased patient population. It is Pittsburgh. It's not, a big city. The vast majority of my patients are white. It is not terribly diversified. And so again, maybe the patient population that is coming to my office is not representative of everybody with Parkinson's disease. And maybe if I had a more, representative population, then maybe I would see those things more. I don't know. But I thought it was very interesting when I went to look for it, because it does seem like dopamine plays a role. Now, again, the only time I've seen the treatments of these conditions play a role is when they're put on antipsychotics. So bipolar patients are usually treated with antipsychotics like Risperdal or Abilify or things like or Rexulti. Same thing is true for maybe some autistic with behavioral disorders. And so those things can lead to Parkinson's symptoms, but I don't think it's very clear. I don't think we know enough about all these things to really see how they tie together. And I thought that was a really interesting question. And as we kind of tease through or really try to solve some of these problems, which I think we're still very far away from, I think we'll have better answers to that question. Any other medication or treatment suggestions for dystonia besides muscle relaxants? Best medication for cognitive impairments and hallucinations with Parkinson's. So with dystonia, and dystonia it comes in a variety of things. So dystonia just means abnormal muscle contractions leading to fixed or twisting postures. In my Parkinson's disease patients, probably the most common form of dystonia is toe curling or foot turning in. Across the board, the most common adult form of dystonia is cervical dystonia, where you get a head turn or tilt or a multidirectional head tremor. But that's not always related to Parkinson's disease. That's more of a standalone condition. And when we think about treatments for these things, muscle relaxers do help sometimes. But the other things I'll use is there any correlation with your Parkinson's disease medicines? Sometimes people notice dystonia when their pills wear off. Some people notice peak dose dystonia when their pills overshoot. And if that's the case, then really the best treatment is to try to smooth out the ups and downs of your Parkinson's disease regimen. If that's not the case, if it seems more random or we can't adjust your medicines, then not only do I use muscle relaxers, but I'll use medicines that work on acetylcholine. This would be cogentin or artane. However, they have a hefty side effect profile. You can use benzos, but again, they have a hefty side effect profile. If it's a focal form of dystonia, then sometimes Botox or botulinum toxin injections can help. And sometimes physical therapy can help too. And so there are some choices, and there's not a lot of choices, and there's not always great choices, but there are some choices that may be able to be helpful outside of just muscle relaxers. And again, from a cognitive impairment standpoint, the medicines that I use are really the Alzheimer's disease drugs. I won't go back into that. And in hallucinations, we still run into the same problems. Again, if the hallucinations are driven by the medications, carbidopa, levodopa, pramipexole, ropinirole, Nupro, Noriance, whatever, then if we try to decrease those, then sometimes we can help with the hallucinations. If that's not the case, or if we can't get away with taking away some of the medicines, then we'll use Nuplazid, which is the only approved medicine, or oftentimes you'll see us use Seroquel or medicines like that, which are off-label but still used a lot. And we try our best. I think that covered that question. And I'm drinking orange and spice tea, which is not really a tea. It's really a tropical or botanical blend, but still good nonetheless. And then the last question that I got in my email was about Rally MPPS 128 probiotic, which I have heard of. This is one that is marketed specifically for Parkinson's disease. In my opinion, and I actually went back as I wanted to see if I wanted to change my opinion, but my opinion really hasn't changed. We've known about the gut problem in Parkinson's disease for 20 plus years. They've been working on this for 20 plus years. We know that the gut and the bacteria in the gut and the flora are different in people with Parkinson's disease compared to quote unquote normal people, which I don't know what normal people are, but theoretically they exist. And they've been working on trying to correct the gut bacteria for as long as they've known it's a problem, which is a long time. Now, there are certain ways we try to enhance good gut bacteria with, probiotics, prebiotics. They've actually looked at stool transplants or various ways we can try to get the gut flora back to a more normal flora as opposed to an abnormal flora, with some mixed results. And the Nerali specific probiotic has these specific, bacteria in them that are theoretically the best ones, or the ones that are supposed to be the most helpful. And I couldn't remember the data behind it. So I went to their website and I looked up their research, and their research is kind of iffy in Parkinson's disease. They did one study that was not randomized. They basically gave, I think it was like 20, 25 people Nerali, and they saw if it helped. And they did get good reports that not only was their non-motor symptoms better, but they thought their physical and motor symptoms were better as well. Now that's great, but that's not enough to get a recommendation from me. I really need to see much better randomized controlled, bigger trials with formal testing that we really use in most drug trials to get good results, which they probably are never going to do. And that's okay, because they're not going to make up their money for performing that trial. And so I liken this to a lot of other supplements. It seems reasonable. We know there is a lot of scientific rationale behind trying to help the gut do better in terms of helping people with Parkinson's disease do better. Their science makes sense. It's logical, and their study was relatively good. It's just not enough for me to say, yeah, everybody should be doing this. But it also can be a little bit pricey. And so my usual recommendations are, it doesn't seem toxic. It has scientific rationale. So as long as it's not putting you in the poorhouse and you want to take it, be my guest. Again, there's not enough good evidence or research trials in it in Parkinson's disease for me to give you a recommendation. But at the same time, I think it actually has better evidence than some of the other supplements out there. And so if you want to try it, be my guest. All right, those were the ones that I had an email. And so now let me scroll up here to the top of the chat box, which is the best place to put your questions, and I'll start doing the best I can. What do I do if I take carbidopa levodopa pill by mistake? Great question. I'm taking 3 per day. Last night, who knows why, I took one at bedtime around 10. What do you suggest I do in that case? I just went with my regular schedule, taking one at 6:30 in the morning. I haven't felt any ill effects. I mean, that's probably fine. We know that carbidopa levodopa is really not a long-lasting drug. That's probably one of the biggest downsides to most of the medicines that I use in my Parkinson's disease patients. And so if you have a few hours between doses, I don't think it's really going to be that big of a deal. In fact, maybe it'll help. Maybe you needed an extra one. I don't know. Um, if you took one and then we're going to take another one and you were due for your dose maybe an hour or two later, I'd say maybe delay it or maybe even hold off on it on the off chance that it might make you dyskinetic or give you hallucinations. But again, realistically, if that happens, it's a side effect of the medicine. It will wear off once your medicine wears off. And so I don't get overly worked up when people take an extra pill here and there. In fact, I use that to my advantage a lot of times in my patients, where I'll say, look, we don't want to increase your medicine across the board, but maybe some days you need a little bit of a boost. Take an extra pill and see what happens. A lot of what we do from a treatment strategy standpoint is trial and error anyway. In terms of here, try this, change that, tweak this, let's see what happens, and then we adjust based on the end result. And so if that happens again, I wouldn't get too worked up about it. I don't think your risk is going to be overly high. Just kind of see what happens and wait it out. I was recently on an anti-inflammatory for my hip injury, and my Parkinson's symptoms improved. Have there been any use of these drugs for Parkinson's? They have looked at them, anti-inflammatory medicines for the motor symptoms of Parkinson's disease, and the results have been questionable or iffy. And again, I wonder if this is coming back to what I talked about in the medical marijuana idea. Again, if you're in constant pain because you have a lot of inflammation, all of your symptoms are going to be worse. Or if that's keeping you from sleeping, all of your symptoms are going to be worse. Now, even if you take that a little bit one step further, we do think, or there is some evidence that inflammation is a big problem in Parkinson's disease, perhaps even the underlying cause of the brain changes that you get in Parkinson's disease. And so maybe there is something to it. We just haven't been able to study it correctly, use the right anti-inflammatory in the right patients at the right time. That's my guess, is that we just haven't been able to show that they're helpful. But I've had plenty of patients tell me that, hey, I get a pain medicine for my knee and all of a sudden I feel like I'm moving better, or I'm on an inflammatory medicine or an anti-inflammatory medicine for my arthritis and I feel better overall and my tremor is better. I mean, I think this is more than just a correlation, but I don't have evidence to support it. And I think there's probably a lot of reasons why that could happen, that I don't think we've teased out yet. And so again, the evidence isn't there enough for me to put my patients with Parkinson's disease on anti-inflammatory medicines. But I'm also not against treating pain. I'm not against treating inflammation or arthritis or things like that. And if we get secondary benefit in Parkinson's symptoms, well, then it's just an added bonus. And so I think there is something to that. I think the research has had a hard time trying to show what works and what doesn't. But at the end of the day, I think it's interesting. And again, I'm glad it worked for you. There is talk about stem cells. So there's talk of success with stem cells introduced in the brain. How promising is this and what is the success ratio? Well, I don't know what the success ratio is because at the end of the day, we're still preliminary in the trials. There were actually two, we'll call them trials, that were just in the news recently about successes. I can't remember if this was in Japan or if this was in China. I feel like it was in one of those Asian countries, but I can't remember offhand. I might be making that up. But they were actually having preliminary success in implanting stem cells into Parkinson's disease patients. But it was early. Again, all of this is still early. At Harvard, they've been working on stem cells for 30 years. They've had some successes. They've had some setbacks. Canada was running research trials about 30 years ago in stem cells with some successes and some setbacks. And so, again, I do think it is a promising idea at some point. And my thought is your thought, right? Is that in neurodegeneration, and this includes Parkinson's disease, Alzheimer's disease, the Parkinson's plus conditions, you lose the cells. In Parkinson's disease, the cells that produce dopamine disappear. And we do not have a medication that makes you regrow cells. At least not yet. And so again, the idea of stem cells, having these cells that can turn into the cells you want them to turn into and produce the things you want them to produce, seems like it really makes sense for brains that don't have enough cells or the cells that are needed to produce the things it needs to produce. And so, again, this is why we've thought about stem cells as a treatment for a really long time. I just don't think we're there yet. Again, they're still trying to work out the right type of stem cell in the right type of patient, implanting it via the right mechanism into the right place to get the control that we need to produce the results that we're looking for. Every time a study comes out, I think we're one step closer. And this is one area that I am as optimistic as I get, which is not very, because of everything that I just mentioned. It's just I need to see better evidence, and everybody agrees with this. I'm not alone in this. There was just a journal article that I read where they were talking about this, and even the movement disorder specialists who kind of give their opinions were all like, "This is all great, but we're still not there yet." And so again, more to come on that. I'm always interested in more studies on stem cells because I really do think that is the only way that I know of that we can actually regrow cells. And when the problem in the brain, or one of the part of the problem in the brain, is loss of cells, regrowing cells would be a way to correct that. So that is one area of neurology and medicine that I am interested in. It's just not there yet. So success ratio, I'm not sure because I don't think we've had enough success to give you a ratio yet. But I do think you're going to continue to hear more and more research on stem cells. And the question, right. So I learned a lot so the question, more of a statement, was the question arose from family of driving. Dr. Baser referred me to the driving school to take a test and then provided her with the paperwork after my day of driving. And so at the end of the day, I learned a lot of what I do from Dr. Baser. She trained me way too many years ago at this point, and still I still hear her words coming out of my mouth half the time when I'm talking. And so that's probably where I learned it from. And I'm not saying that people have not passed that test. I actually have had a couple of people pass that test, but these were not people that I specifically sent for an on-the-road test. And so that's why I use that as my kind of bench post. That is a great question. Is Parkinson's dementia the same as Lewy body dementia? You're really asking questions that divide the movement disorder society or divide the movement disorder specialists into very polarized. Hey, they're great questions. They're great questions because we all ask exactly these questions, and then we let the researchers try to tell us the answers. So there are plenty of movement disorder specialists out there that think Parkinson's disease and Lewy body dementia is a spectrum, that it's all one condition, and it depends on where those Lewy bodies deposit, how quickly they aggregate, and it's actually one disease, just one spectrum of disease on different ends of that spectrum. I don't know the answer to that question. And so we know that the underlying pathology, the Lewy body, which is really a clump of alpha-synuclein misfolded, clumps together and gets put in this Lewy body, this protein complex, is in both Parkinson's disease and Lewy body disease and multiple systems atrophy and pure autonomic failure. All of these diseases, and I'm going to call them diseases because that's the lack of a better term, have the same underlying pathology. So when you scan brains or when you slice them open, stain them, you can see these purple blobs. Does that mean they're all the same disease? I don't know. And so again, are you one of those people who thinks that because they all have the same underlying pathology that maybe this is just one spectrum of the same disease? Or do you really think, are you the other half of movement disorder society and specialists who say, nope, these are two completely different things who just happen to share an underlying pathological biomarker? I don't know. And so the answer to that question is, I don't know. There are variations of Parkinson's disease dementia, some of which resembles Lewy body dementia. Now, the hard part is the hallmark of Lewy body dementia are florid visual hallucinations. And in my simplified brain, I've always differentiated the hallucinations that you get in Parkinson's disease from the hallucinations that you get in Lewy body disease. And maybe I do this for my own simplification, I don't know, but it makes sense. And the way that I always teach it to my residents or students or anybody who's rotating with me is I say the underlying cause of the hallucinations is different. In Parkinson's disease, I really do think the hallucinations are a side effect of the medicines that I use to treat Parkinson's disease. carbidopa, levodopa, pramipexole, ropinirole, reticutin, blah, 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 every medicine known to man. And if I took a true Parkinson's disease patient who was having hallucinations and I stopped their medicine, their hallucinations would go away. Now, I don't do that, but that's what I have in my mind. And in Lewy body dementia or Lewy body disease or dementia with Lewy bodies, the hallucinations are a manifestation of the underlying disease itself. And so it is amplified by medications, but it is triggered and caused by the disease. And really, I feel the most confident making the diagnosis of Lewy body disease when patients come to me hallucinating before I've even put them on any dopamine medicines. And so I know that those people are hallucinating because of their underlying pathology. And so in my simplified brain, I view them as different. But realistically, there are plenty of people out there that don't, that think it's all the same thing. I'm not sure. How I go about treating them is fairly similar. So the medicines that I would use are very, very similar. Well, they're all similar to the Alzheimer's disease drugs. It's just we have to think about hallucinations and progression and movement and things like that. And so I'm not entirely sure the answer to that question. I view them as distinct and different, but there are plenty of people who view them as exactly the same thing. You could argue that the treatments are relatively the same. And that's just one of those questions that will be debated in movement disorder society meetings until somebody actually figures out a way to know the answer. Yes, I love this question. Man, you guys are on fire today. As Parkinson's disease is really a syndrome, which you've heard me say, and I think that because it is a diagnosis based on symptoms, although this is also a very hot topic in the Parkinson's disease community, in the movement disorder society community, as to whether or not we should change the diagnosis criteria of Parkinson's disease to include a biomarker. Very contentious debate at the last society meeting. Because again, that would disclude some patients who we would now diagnose as Parkinson's disease as having that diagnosis because they don't have the underlying biomarkers. But that's a different story. But I do think it's a syndrome because you get the diagnosis based on your clinical symptoms. So I agree that Parkinson's disease is really a syndrome due to snowflake variants. I like that. Besides the benefit of exercise, is there one or more constants that you have identified to show benefit? Humor, stress relief, diet, anything else? And I think this is a great question because I was actually giving a talk to neurosurgeons and neurologists a few years ago, and I was giving it on the benefits and power of exercise. And I don't know if any of you guys know Dr. Joe. Dr. Joe has been a pioneer in neurosurgery. He's been around for a very long time. He has invented things in neurosurgery. He has things named after him in neurosurgery. And he asked me a very similar question, which is, what about laughter? And he basically said that in my waiting room, I should put on the Three Stooges because that would actually help people do better as much as exercise or any of the medicines that we use. I haven't done that. In fact, if you come to my office, it's basically an Allegheny Health Network commercial that I am not on and had nothing to do with, by the way, and not the Three Stooges. But I always thought that was an interesting idea. Humor or laughter is great medicine. Stress relief is obviously great medicine. Diet, there is some mounting evidence. Again, Mediterranean diet is probably the best diet, and that has some evidence in Parkinson's disease, but we're learning more about diet and anti-inflammatory diet, low processed foods diet that maybe are helpful. And so this basically encompasses overall being very healthy, right? You know, it's not uncommon in my office for me to tell people, look, the absolute best things for you are things you don't need me to tell you are the best things for you. Everybody on the planet, I think, knows that, hey, you should probably eat healthy. Healthier diet is probably better. Less fast food, less processed food, you know, more fruits and vegetables. That's not rocket science. You don't need me to tell you this. You don't need me to tell you that you should probably stay hydrated and you should probably get good sleep and you should probably get up and move a little bit more. And you actually do have to get out of the house and interact with other people because social isolation is really a killer. COVID taught us that more than anything. And so we know that overall being healthy and doing these things is good for everybody. So there's no good reason why it wouldn't also be extremely good for people with Parkinson's disease. Now, I don't know the studies on these things. I don't know that they've ever been truly looked at. I see how hard it is to even prove that exercise is beneficial in Parkinson's disease or disease modifying. So I can only imagine how difficult it would be to plan a study to look at humor and laughter or stress relief. Again, I personally, and this is my opinion, think that these things really are beneficial and as healthy as you can be are probably good for you. And so again, I think there's something to it. I don't know that there's any actual evidence behind it, but again, you don't need me to tell you that healthy choices are better for you than unhealthy choices. What about naltrexone? And Casey, I don't know. I skipped over. Oh, that was a Brain HQ thing. Okay. What about naltrexone for Parkinson's disease? Again, another thing that has interesting and not a lot of data to support its use. So I learned about naltrexone and particularly low dose naltrexone, so quote unquote LDN, from some of my patients for a variety of things. And if you Google LDN and benefits, it's kind of like medical marijuana, and it basically causes world peace if you read enough things. And so there's not a lot of evidence or studies looking at it in Parkinson's disease. I have had patients ask for it in terms of its anti-inflammatory properties for Parkinson's disease as well as cerebellar ataxia. And I think I had one tick patient ask me about it. And again, I think there is some scientific rationale, so I'm not against trying it, although there's not a lot of good evidence or good studies or good research behind it. And so it's one of those things that as long as it's cost effective and it's not going to be toxic or you're going to get it from a reliable source, I'm not against trying it, but I don't have a lot of good data behind it to recommend it or say, hey, yes, this really is a good thing for you. But I think there is enough scientific rationale that it's not unreasonable. Are there rules about how fast and what amount you can turn down the amplitude of DBS there? I mean, have any of your Medtronic DBS patients moved from regular to adaptive, and did it provide results? I do not have any adaptive DBS patients, although I am extremely interested in it. I actually just gave another grand rounds talk to neurology and neurosurgery on the new and interesting things in Parkinson's disease. And it led me to look more into the Percept from Medtronic and the adaptive DBS. And I'm very, very interested in seeing how we use that, how that goes. We have a new surgeon coming up from Florida starting in July or October to go along with a couple of surgeons that we already have who do deep brain stimulators. And we're going to sit down and have meetings about this because I'm very interested to see how adaptive DBS goes. So adaptive DBS is basically a self-programming, self-learning deep brain stimulator, which I've been asking for a long time. It turns out there are certain circuitry patterns that we can measure and record in patients with Parkinson's disease that are abnormal. And then when we record these abnormal circuitry patterns, we can then stimulate or cause the deep brain stimulator to fire in a certain pattern to correct that firing frequency. That is adaptive DBS. And I think I think it is going to be at some point the wave of the future for deep brain stimulator surgery. The better we get at it, the more we see what it can and can't do. But we have not done it yet here. In terms of your original question, which is how fast can you and what amount can you turn it down? That's very subjective. I do not know if there are hard and fast rules. That is going to be very subjective with the person that's adjusting your DBS. Everybody has different kind of okayness. That's not the right word I'm looking for, but you get the idea with how fast they can and can't go. Comfort level with how fast they can and can't go. And so that's going to be a little bit subjective. I don't think there are hard and fast rules as far as I know. But again, in terms of your adaptive DBS question, I'm very interested in seeing how that goes. And we'll kind of see more to come on that. That is an area that I think has tremendous potential. And you're going to be hearing more about it, I think. Again, CRISPR, which is again, and a lot of what, enzyme replacement infusions, you're seeing GDNF, which I think Dr. Van Laar was talking about, or some of these enzymes in these different ways that we can try to correct the underlying or reverse some of the underlying pathology that we know in the brain. Again, I think the jury's still out. The studies still have to be done and completed, and we really need hard and fast evidence to give you more on that, along with stem cells. And so, Dave, I'm going to give you more answers once they come to me. Man, great question. If you die from Parkinson's or from the medicine side effects or from whatever you die from, because ultimately it's some side effect or complication of Parkinson's disease, what does it look like? And when do caregivers recognize when the body is wearing out and shutting down versus a Parkinson's freeze? And that is a great question. Um, it looks different. It looks different in everybody. It looks like a pneumonia. It looks like a fall. It looks like just a failure to thrive. And this is one thing that I myself have not been very good at. Um, and this comes down to when is the right time, or what are we looking for to transition to palliative care or hospice care, or think about those things, or have end of life discussions, which makes nobody comfortable. And I don't know the answer to that question. There's a lot written about the answer to that question. There are volumes of journals written about when is the right time to think about these things. What does it look like? How do you recognize these things? But I'm still not very good at it. And I would argue that the vast majority of medical care is not very good at it. We underutilize the palliative care and the hospice team significantly, and they would be absolutely the best resources to help you answer those questions. It does look like a little bit different for everybody. And it's tough because the best and probably the most common way that patients describe an off spell, I feel like I'm dying, right? And so it is really hard to say what is just progression of Parkinson's disease, what is just freezing or motor fluctuations versus what is actual, deterioration or heading in a bad direction to the point where we really should stop thinking about how to be more aggressive with the medicines and start thinking about, not that I'm not thinking about this all the time, but start thinking a little bit harder about just comfort. End of life care, keeping you out of the hospital, whatever your wishes are. That is one area that I, as a provider, struggle significantly with. And I will come to you in a second, Donna. I have not come to a great way to transition my conversations. I have not come up with a great, this is what you should look for, and this is when we should have that conversation, and this is how it should go, and this is when we should utilize palliative care and hospice care. It is a significant deficiency in my own ability, which I'm trying to work on, although slowly. But that's a great question. And it's a really hard answer because it's a little bit different for everybody. Go ahead, Donna. What were you going to say?
Just that some of the characteristics that you see kind of, I think, in end-stage Parkinson's, if they have stimulation-induced dyskinesias or they have dopamine-induced dyskinesias, they lose body weight tremendously. And they go below the normal BPI. And then they're having freezes where they're not up enough to even move, let alone exercise or eat. So is that, and then if you do call in hospice, they tend to stop dopamine. And how does that work on Parkinson's patients that have been like we don't know how to get off dopamine yet at end of life? How do you transition from dopamine to non-dopamine? So those are some of the questions that need to
Yeah.
answers for because it's
And
very scary.
and they're great questions. And I think a lot of people have those questions. And I have a couple of answers to them. Is you're right. There are some things, and I have papers on this too, that are known to suggest, okay, we should really transition to hospice palliative care end of life. And significant weight loss is one of them. Multiple falls, recurrent hospitalizations, sometimes recurrent infections, urinary tract infections, pneumonia. These have all been looked at and are documented in some way, shape, or form. And realistically, they should all be signs that we should at least be thinking about it, that we should get you to talk to them, because palliative care and hospice are actually two very different things, and you guys should be aware of that. Sometimes one palliative care transitions into hospice, but they actually mean two different things. And so those are all good reasons when somebody like me should really be suggesting, hey, why don't we get them on board? I'm just not very good at it, and I'm working on it, but it's a deficiency in me. But I think everything that you mentioned is exactly accurate. And they're all times where we should be thinking about, okay, what's the strategy besides here? Just take more medicine. Let's see if we can work on this. The only thing that I would argue against what you said is that in my patients that have been on palliative care or hospice, they have not had to stop their dopamine medicines. They absolutely cannot get therapy, which drives me bananas. and is probably the thing that I like the least about hospice care, is they absolutely refuse to give my patients any type of physical therapy, speech therapy, which I think actually is comfort inducing, but I lose that battle every time. But my patients that I've been able to get on hospice for whatever reason have been able to maintain and take their medicines, and they've been able to continue to come see me as a specialist. That may not always be the case. That's just, again, I only know my own experience. And so different hospices may have different rules or so on and so forth. But that's been my experience with it so far. But again, I think your questions are extremely valid and extremely important. And one of these days, I'm going to try to figure out how to do it better, because I do think those are all really hard. And those are not questions or things that I think a caregiver should have to be the one to bring up or figure out. It's me. I am the problem on that one, and I take full responsibility for it. I just have to figure out how to do it better. But that really is exactly how the conversation should go. You should bring these ideas up and say, look, I'm worried about this, this, and this. And again, if your doctor or if your neurologist or if your movement disorder specialist isn't giving you the answers that you want, then even you are allowed to suggest, hey, what do you think about palliative care or hospice? These are really good resources for those kind of things. And end of life care, while it's written about and while there are definitive things, it is not very well widespread, very well known, and very well done, at least in my own personal experience. And so I think those are all good topics to bring up, and they're just things we have to keep working on. Does
Well,
anybody go ahead?
one
Quick.
thing is if your PCP brings it up before your neurologist, because you see your neurologist every 3 to 6 months, but you may be seeing your PCP for other stuffs. But then we saw the neurologist and then we see the PCP and he's bringing it up, but the neurologist didn't say anything a week earlier. So then
Yeah,
it's very
yeah.
confusing.
No, it is. And, PCPs may be a little bit better, but they're not always great. It's not an easy situation. I agree.
And then
And we
I
don't,
just don't know about the dopamine because I've heard stories that they start morphine and cut the dopamine off because
yeah,
the patients can't swallow or something.
I haven't had that experience yet, but again, I don't, believe me, I'm not the end all be all know all. All right, I'm going to answer the last couple of questions and then I'll finish up here. Where was I? It was about the Nintendo DS. Has anyone tried Nintendo DS? I think it helps with cognition, recognition, and speed. There are a lot of games out there. I don't know about the Nintendo DS, but I have some people that use the Oculus, which is that immersive kind of virtual reality thing for physical exercises, brain games, things like that. But the short answer is I think it's reasonable. If it's fun, you enjoy it, it seems to tax your brain or your thought process, I think it's reasonable and I'm all for it. I don't know if there's any evidence to it, but again, I think it's not, I don't think it's a bad idea. I've heard that old brain probes work with new adaptive technology. Yes and no. So we're back to the DBS question. So at the end of the day, there is some ability to transfer or transition from like a Medtronic generator to a Boston Scientific generator or an Abbott generator. Whether or not some of the technology is actually in the leads itself as well as the generator. And so just because you switch from one to the other doesn't mean you get all the kind of ability and uses of everything, but there is some work with, changing older brain probes with new brain probes with newer generators and mixing and matching these things. And it does make things a little bit trickier, but at the end of the day, it's not impossible. You just don't always get all of the same benefits. One second. I think I got one more question. I find it interesting that my PCP usually seems to suggest that due to me having Parkinson's, in the event that I have a cardiac arrest, that I not have resuscitation. Hmm. I don't know what I think about that, because at the end of the day, that's a very, very personal and subjective decision, right? And I have Parkinson's patients that are running marathons. I honestly don't think that that person is going to be a DNR, DNI, or a do not resuscitate. Conversely, I have patients that don't do so well and that maybe are at end of life care and wouldn't want heroic measures done. And they should absolutely have that written in their chart that they would not want CPR, they would not want resuscitation under the situation of a cardiac arrest. I do not think it's appropriate that just be to across the board, hey, you have Parkinson's disease, you should have a do not resuscitate order. That, to me, that doesn't sound like a great plan. But I do think it should spur the thought. I think, myself included, we should all really be thinking about what do we want, what don't we want, what would we want, what wouldn't we want, and then put it on either tell somebody who is going to be really important, or even better than that, it needs to be put on paper. Because at the end of the day, I can tell you, I have been in enough codes in the hospital, none recently because I'm a neurologist, very subspecialized, but in training, you train through everything. And so in stroke and epilepsy and in general medicine, I've been in enough codes to know that when somebody has a cardiac arrest and they're doing CPR or they're resuscitated, that is not the time to try to figure it out. That is not the time you want your significant other to be trying to make those decisions. No good and thoughtful and well thought out decision has ever once been made in that situation, in my experience. And so, unfortunately, the vast majority of us don't think about these things, don't write these things down until that event happens, right? I mean, unfortunately, that's just the way of the world. And so, as a fully upfront, I do while I don't think it makes sense for your PCP to say, hey, you have Parkinson's disease, you should not, you probably want to lean towards the DNR in the situation of a cardiac arrest. I don't think that's a great idea. I do think that each and every one of us should think about these things and should probably have an advance directive. There are things called a POLST, which is a physician order, or an advance directive. There are different ways you can go about doing this. But if you really want your wishes to be maintained and done in that catastrophic event, you really have to have them written down ahead of time. Because I can tell you, when you're having a conversation with somebody, when CPR or resuscitation is happening in an emergency room or in the hospital for their significant other, they do not make good decisions. And the answer will almost always be do everything. Even if that is not, and then later on we decide, okay, no, that wasn't what she would have wanted or he would have wanted, let's undo that. In the heat of the battle, in the heat of that time, thought out good decisions are not made. And so the best time to do this is ahead of time when you're not in that situation. Think about what you wouldn't want to do, write it down, fill out a form, however you want to do it so that people know what you would want. That is a better way to do it. And with that, I will stop and kick it back to you, Casey.
Okay, thank you, Dr. Leichliter. We're going to conclude, and guess what? We're missing July because it's right around July 4th. It's on July 3rd, but we'll resume on August 7th. I checked, and I'm going to have Dave. He just wanted to share just for a moment about advocacy. We're also focusing on advocacy, as well as Dave, who is on the other side of the state, but it's all for the same cause. So Dave, if you'd like to just share a few words and then we'll conclude.
Okay, there's a bill on the state house, HB 1135. It bans paraquat, which is linked to Parkinson's, Lewy body dementia. I suspect ALS strongly. And it's banned in 67 countries, including one of the countries that makes it. I have contacted chairman of the Consumer Protection Committee. And I think we need to start bombing that guy to get that bill out of committee and onto the floor, as well as the people that are on the floor that are going to vote on this bill. Yeah, give me a hand, guys. I'm writing a generic letter to the editor that maybe we can publish in 50 newspapers. If people send them to their local newspaper, they don't have to know that somebody else wrote it. But hopefully we'll run that by Casey and we can come up with a great, simple letter.
Absolutely. And Diane on our team has already started as well. The more voices, so please contact your representatives. We really want that ban to happen. More on that. Thanks, Dave. Thanks, everyone, for joining. We'll see you on August 7th. And thank you very much, Dr. Leichliter. Bye, everybody.
Thanks, guys.